Hi, everybody. Welcome to the Harrison Symposium. Just delighted to have everybody here today. Thank you so much for coming. And a special thanks to, where's Usha? There she is. And to Kristen. Where's Kristen? Outside. They've done an extraordinary amount yeah, thank you. They've just done an extraordinary amount of work on this, and I think they've put together an incredible program for us today. We really have an extraordinary group of participants, and hope you'll enjoy the day. And thanks especially to those of you who've traveled from far away to come. I think that in the spirit of Mike Harrison, Dr. Harrison, who we're honoring and collaborating with today. This really is sort of a expansion of his favorite day of the week, which is the lab meeting that he has. And yeah, it's a big lab meeting. And so in that spirit, I think we would encourage all of you to be interactive. There are no bad ideas in Mike's. I remember, many ideas that people would pitch that I would thought, wow, that's just a terrible idea. And somehow Mike would make gold out of those ideas along with whomever was pitching those ideas. So we really encourage the interactivity, and I think some great things will come out of this. These days, I think, always bring out the best in everybody who participates. I always remember just being inspired and exhilarated by the things that happened for this. The one thing that I wanted to do, because really one of the big legacies of Mike is this meeting, but it's also the home for this is the Division of Pediatric Surgery here at UCSF. And our division has done some incredible things, and I know many of you know a lot about it, but really we've done a tremendous amount of innovation. It's really been centered on collaboration. And here in this picture, you can see on the left are the clinical faculty that we have, and it includes our Oakland partners and our San Francisco partners. And in the middle, you see Mike, and then you see on the other side are our laboratory investigators, Kyle Cromer on the top and Tippy McKenzie on the bottom here. And we'll talk about some of the things that they're doing. Just wanted to focus on some of the research things that are going on in our division. So Chris Newton that you see on the bottom right there has done an extraordinary job. I think he might be the single most funded surgeon in the country. And that's a high bar because maybe the second most funded surgeon might be Tippy McKenzie, who's sitting right over there. But Chris has, I think, approximately $80 million of federal funding to really investigate what the needs are in pediatric disaster preparedness. And so that's been very timely, obviously, with the pandemic. And so his first grant came with the RAPM grant, which is the Western Regional Alliance for Pediatric Emergency Medicine. And that was a huge grant of initially, I think it was $7 million. And then several years later, he got a $60 million grant. It was one of the two national PIs for this. And then this is all built on itself. And so he's doing an extraordinary job of leading disaster preparedness for kids throughout the country, which is a huge need because the adult hospitals during the pandemic, we really realized that there were many of them, because of the strength of the children's hospitals, really weren't designed to take care of children in mass. Unfortunately, during the pandemic, we didn't really need that, but we could obviously see a scenario in which children are more infected than adults were, which was not the case with the pandemic. Also, I want to highlight one of the things that our division is really dedicated towards is diversity and health equity. And so Daruk Ozgadis and many of our team are devoted to this. But Daruk was recently recruited back. So Daruk was one of our surgical residents, and we were really delighted to recruit him back almost 4 years ago. And he's leading the Center for Health Equity in Surgery and Anesthesia, CHESA, at UCSF, and it's to advance equity, not just worldwide, because his background is in global health and global surgery in particular. And Daruk is an extraordinary guy. He speaks 7 languages fluently. Like, English, obviously, he's Turkish, but then he speaks Mandarin and Bugandan and just, and it's really interesting to see him interact with people of different backgrounds, but he just speaks these languages fluently. And it's really wonderful to see people who come into health with sort of a hesitance, and then you see this guy speaking to them fluently in their native language, and you can just see the relief in patients. So it's a remarkable thing. And he's really expanded this. He is really, I think, the seminal leader in global surgery in the country. And it's just remarkable to have him as a partner. One of the things that I think that Daruk is doing that really, I think, is appreciated by many is there is a bidirectional level of feedback and knowledge dissemination between our partners in low and middle income countries and us in developed countries and higher income countries. And so he set up a fellowship where some of our trainees go to his home base for global surgery is really the United States and Uganda, but other countries are involved as well. But also for them to come to the United States and not only learn from us, but also to teach us what they do, because per dollar spent, they do a remarkable job on the healthcare in their respective countries. So really appreciate what he's done as a collaborative venue for global surgery rather than the traditional model of we'll go there and we'll take care of people. And I think it's just a more sustainable and more respectful model. And as well, as I said, we really learn a lot in this way as well. And then Tippy and Mary Norton lead the Center for Maternal Fetal Precision Medicine, and Tippy has presented at this forum in the past, and she's really doing extraordinary things. Tippy, as I said, is an incredibly funded researcher. She has 3 R1s, right? A Serum, a California Stem Cell Grant, and the ARPA-H grant funded. So, and Tippy, can you maybe just give us like the 2 sentences on the amount of that and what the scope of that is? Because that just happened, right?
Yeah, and we're technically under wraps, but yeah.
Okay, sorry.
We're all family here. This is our lab meeting. Yeah, so it's a grant to do in utero genome editing for sickle cell disease in mouse models, but also some funding to try to take that to patients. It's a collaboration with partners at UCSF, Kyle Cromer and Diana Laird, as well as Jennifer Doudna, who invented CRISPR.
And won a Nobel Prize.
And won a Nobel Prize. And yeah, I'm really excited about it.
Yeah, so. And by the way, Tippy runs the Stem Cell Institute at UCSF. So for a surgeon, that's for somebody who is a clinical pediatric surgeon, it's a remarkable accomplishment. And then, of course, our Pediatric Device Consortium, which is one of the centers of this discussion today, we were recently, just this fall, awarded a renewal of our Pediatric Device Consortium grant. So we're one of 5 centers. Really, the goal is to expand pediatric devices, which is really, if you think about all of pediatrics as an underserved population, I think the FDA has done a great job. We really appreciate the partnership with our FDA colleagues. I think they've just really, it's been a game changer in what is being able to be accomplished in the device space. And then it's part of also our Surgical Innovations program here at UCSF, where we help to lower barriers for surgical innovators across the campus and also help to train the next wave. Just a couple of things. The last slide is some of the honors is that one of the highest honors that we can get at UCSF is a clinical honor, the UCSF Exceptional Physician Award. And it's been in existence for less than 20 years. And when they first started awarding these, I think about 3 people out of the 4,000 or 5,000 physicians got these awards, and now it's up to about 15 or so. But in our small division of less than 11, 12 clinicians, we've had 5 people in our division awarded this, which just also tells you how highly our clinical efforts are appreciated. Chris Newton won the Benioff Children's Hospital Oakland Lifetime Scientific Achievement Award based on his disaster preparedness effort. Two of our faculty, Jim Betts and Jerry Adu, won the Lifetime Achievement Clinical Award, the Bronze Bambino Award at Benioff Children's Hospital Oakland. As I said, Tippy is the stem cell director. Lan Vu, one of my partners, won the Teaching Award in Excellence, one of a couple given out every year at UCSF last year. Willie Moses, who's here, and I saw Daruk is in the back, just walked in, was just bragging about your efforts in CHESA. Won the Watson Scholarship Award a couple years ago, and that just got renewed to expand efforts in diversity, equity, inclusion. And remarkably, we have two people of our faculty in the National Academy of Medicine, Mike Harrison and Tippy McKenzie, which is, really one of the highest bars that one could accomplish. And then Daruk Ozgadis won last year the APSA Humanitarian Award, which is given to one individual. So just in the last several years, this is what our division has accomplished. And so I think this is really Mike's legacy, and it's a really proud legacy. And I think that really the tree of, the branches of Mike's roots and trunks are really going to continue to grow and expand. So thank you, Mike, and thank you to everybody who's come here today. And with that, I think we'll continue with our program, which will be to go on to the very exciting pitch competition. So I'll hand it over to our pitch competition program leader. So thank you.
Thank you, Dr. Lee, for that great opening remarks and kickstarting this symposium and introducing us to the pediatric surgery's exciting, innovative programs and the team. Good morning, everyone. I am Usha Tekedath, a co-director of the UCSF Stanford Pediatric Device Consortium, one of the 5 PDCs supported by the FDA. And it's so nice to see all of you here. I know many more are joining remotely from across the country and around the globe. Welcome to all of you as we move to the PDC's annual Accelerator Shark Tank 2024. So today we will be awarding a total of $250,000 in Accelerator Awards. And this is made possible by our PDC grant from FDA and generous donations from our longstanding supporters like Cottrell Foundation and Hooper family. A big thank you to all our sponsors. And we have 10 teams, 10 finalists pitching today. They were selected from a total of 65 applications around the country. And they will be competing for one of the multiple accelerator awards ranging from $25,000 to $100,000 and other support from PDC in customized advising, mentoring. And now this year, we are excited to have our new partnership with Fogarty Innovation. So some of this team will have a great opportunity to work with the world-renowned Fogarty's Accelerator program. So good luck to all our pitch finalists. Today's pitch competition will be judged by our esteemed panel of judges with diverse and great expertise in the medtech field. Our judges are Avi Rube, Managing Director of Research Corporation Technologies, Dennis Sarins, Chief Operations Officer from Fogarty Innovation, Emma Moran, Director of Strategy and Development from Kobe Cure, Nada Hanafi, a regulatory expert and founder of MedTech Strategy Advisors, She is also a great advocate of DEI and co-founder of MedTech Color. Paul Hooper, information technology expert, philanthropist, and advisor to several early and mid-stage technology companies. Verna Rodriguez, executive director of Master in Translational Medicine, a UC Berkeley and UCSF joint program. Vivian De Rugiter, physician, venture capitalist, and investor with Intuitive Ventures. Wendy Sue Sorensen, pediatrician, digital health expert, and physician executive. Welcome to all our judges, and thank you for sharing some of your time and expertise with us today to help us select our winners. Dr. Williford Moses, a pediatric surgeon from UCSF, and Dr. Anuradha Dayal, a pediatrician from Stanford. Thank you, everyone. Dr. Moses.
So again, I'm Willie Moses from UCSF. As had been mentioned, there's 10 finalists, and each will be given 5 minutes to provide some detailed background as to their innovation. There will be a 3-minute Q&A by our judges and panelists, of which some are obviously on Zoom, and hopefully we'll be able to connect with them should they have questions. Unfortunately, no questions for the audience, but certainly throughout the day, you have the opportunity to engage and interact with everybody who will be giving their presentations. The final presentation will be given remotely, actually. So with that said, the judges will be evaluating based off clinical need, the technology, value proposition, regulatory, and then the commercialization potential with sort of detailed rubrics for each of those to help guide their evaluation and assessment. And so without further ado, I think we'll just go ahead and get started in the interest of time. So again, it'll be a 5-minute presentation followed by 3 minutes Q&A. Yes, there will be a 1-minute sign over there. So just present in this direction. If you're at this direction at minute 4, you may miss that and get cut off, but we won't be doing any hard cutoffs here, sorry.
Vivian here. Oh, okay, please come.
All right, so our first presentation will be by Neola, and I invite them to come on up. Okay. Thank you so much. Yeah.
Okay, ready to start the 5 minutes then. So Neola Medical has developed the world's first medical device for continuous monitoring of the lungs of preterm-born infants with an instant detection of lung complications. And we'll see how we... Oh, here's the click. I'm so sorry. No? Okay. Okay, I'll start all over. Sorry about that. So Neola Medical has developed the first medical device for continuous monitoring of the lungs of preterm-born infants with an instant detection of lung complications. As many as 1 out of 10 babies are born preterm and may depend on neonatal intensive care for their survival. Their underdeveloped lungs can quickly advance to life-threatening complications during their stay in the NICU, and respiratory disease is the most common cause of death for this patient group. 50% of the very and extremely preterm-born infants show sign of what we define as severe disability at age 11 because they lie too long today with their lung complications. And that's the reason why we have developed Neola, Neonatal Lung Analyzer, that is an objective decision support for the neonatologist for an instant detection of lung complications. It is non-invasive, it's continuous monitoring, and it's safe for the baby's vulnerable skin. And as you can see here on the screen, for the first time also, we're able to see where the problem is in the lungs, right versus left side. So the groundbreaking technology is gas and scattering media absorption spectroscopy. So a spectroscopic method completely new that lets us see in real time the lung volume and the free oxygen gas concentration inside of the lung in real time. Current monitoring methods of chest X-ray and lung and blood gas sampling is really old, it's invasive, and it's very slow to show results. With our methods, we can give the neonatologist an instant detection of the lung complications and also show where it is. With checked with both over 100 neonatologists in over 15 countries, we have a great clinical support for Neola. And it's been said that if we can prove in our clinical study that we're doing this year, we could be in every clinic in 5 to 10 years. So we have 7 patent families covering all major assets. We also have medical patents that might let us scale this important lung monitoring device also to other patient groups, and patents regarding our device and disposables. The disposables are changed daily on the baby. We're getting into a growing and non-cyclical market that is estimated to be valued at $3 billion in 2030. It's also recognized for the growing number of patients, very strong margins, and the rising awareness of the need for newborn disease prevention. Our revenue streams mainly come from the Neola device, but also then from the disposables that are changed daily on the baby, and also service agreements. We have a very large growing addressable market of 35,000 relevant NICU beds for Neola device and disposables, then serving more than 400,000 preterm-born infants yearly. We have identified 10 leading children's hospitals that are our target for our first market launch. For these customers, we will bring financial value related to reduced lengths of stay in the NICU, reduced number of blood gas samples and chest X-ray, reduced manual observation time for the nurses, and also get potential reimbursement through the MSDRD payments. So we have established all the scientific evidence regarding the technology validation. We are now just also received great results from an independent clinical study on 100 newborn babies made by a university hospital in Ireland. We're currently in that very exciting final year where we will do our clinical study on preterm-born infants at Lucille Packard's in Palo Alto, followed by a process to be FDA granted. This is a Class 2 device, and we're following a de novo process. Our commercialization strategy is identified in 3 steps. We're currently in the pre-launch phase, where we're gathering all our scientific support for our technical file for the FDA, and we're aiming for a market launch in 2025. We have currently invested $13 million in the company, and in 2025, we need another $4 million to start also recruiting a sales team. I do this not alone, but with a great team of professionals and a very strong board of directors with experience of taking new innovation to market. Thank you so much for letting me present today, and do join our journey and improving the care of preterm-born infants.
And if you don't mind, if there's some questions, I don't know if any of our judges have any questions. A couple minutes left.
I think it's on. Yes. Curious regarding the complications that's able to detect. I saw pneumothorax. Any other type of complications, or can you elaborate a little bit more to that?
Yes, so will be an objective decision support both for sudden complications that can be hard to detect today, so pneumothorax, atelectasis, but then also what's very scary today are these really slow negative trends that then typically leads to a crash. So with that, the neonatologist can scroll back in time to see if this baby is getting more and more stable, or it might also be that when we're in clinic, that this could be a way of deciding if the baby is ready to be pulled off mechanical ventilation.
Great. Wendy?
Hi, thanks for the great presentation. Nice to see you again. I have two questions for you. First, in regards to just including family caregivers and others who are invested in a neonate's life, will they have visibility into that continuous monitoring, or is there a pathway to include family visibility into the continuous monitoring?
We haven't looked at that, so I think that's a great point for us to elaborate further on. We have in our design made sure that the user interface is really friendly and also easy to follow, because we know that typically the parent is sitting next to the baby.
Yeah, thank you. And then secondly, just in regards to the revenue model with the disposables, are the disposables really part of the revenue, or could they be replaced with a non-need of disposables to save hospital costs and family cost?
It might be. In our research with over 100 neonatologists and nurses, it's been quite clear that it's preferred with disposables for safety reasons, because of the preterm born baby's very sensitive skin.
Thank you.
I was wondering, other than your device and the disposable, is there anything else that's needed to be able to monitor? I mean, I was wondering, with the technology, do you need like a special gas to be able for the babies to breathe, to visualize, or anything?
No, nothing. So it's just 4 probes that will be placed on the baby's chest. We have been working very hard with our technical teams to make sure that they're absolutely tiny, to be able to fit also on the very smallest babies.
Okay. And do you see this as a potential growth area for adults with emphysema, for instance?
Yes, we do. We have seen a lot of interest from other areas where we could definitely need lung monitoring. So both children that are under surgery is one of them, that we're actually having a research project right now to see if we can scale to that in quickly. But then also, of course, older patient groups, and we could also see that from the COVID patients that we might have, if we were ready, we might have been able to do some real change there.
Thank you.
Fortunately, that's our 3 minutes, but thank you so much for.
Thank you. Thank you so much.
So our next presentation will be Rapid Scan.
Okay, so that doesn't happen again. What's the trick? Use this one instead?
Yeah. Advancing.
Awesome. Good morning. Wow, that's a tough act to follow. Thank you for that work. I'm now, seriously, as someone who works in newborn space, I'm like, that's amazing. Okay, let's get to it. I'm Anna Marie Sarnin. Thank you so much for hosting this, by the way, on behalf of everyone that's working in pediatric innovation space. This is such an exciting group to be part of, and I'm very appreciative. Bloom Standard is developing the first completely autonomous self-driving ultrasound device to earlier diagnose cardiac and cardiopulmonary conditions in babies and young children. This is my own daughter, Eve. She looked perfectly healthy when she was born, but she was diagnosed at 3 days old with critical heart defects. And she is really only alive today because of access to an early diagnosis and treatment for her condition. And one of those critical tests was ultrasound. So 1.3 million babies are born each year with heart defects. That accounts for 10% of infant mortality around the world. And ultrasound is essential for every single one of these kids. A lot of these deaths can be prevented through earlier monitoring or detection of those conditions, yet 90% of kids don't have access to ultrasound in their local communities of care or where they're born. And they are 2 to 3 times more likely to die from those conditions if they're detected late or deterioration is not assessed in a timely manner. And it's commonly used, of course, in high-level medical facilities, but virtually non-existent in the places babies are born or seen for routine care. So Rapid Scan is a 3-minute place and scan automated imaging device to detect these abnormalities. It uses novel beam steering technology and serves as a clinical decision support aid. So we're not replacing what happens at those high-level centers, the places where my daughter's had 65 echocardiograms in her lifetime. We're just getting kids there sooner, faster, safer. The FDA agrees this is novel and granted us our breakthrough device designation in December of last year. So why do we need something different right now? Mostly because we're relying on stethoscopes pulse oximeters, or really, really big devices in the referral pathway. That's in some cases broken, in some cases not very time sensitive, and in other cases just frankly unsafe. The 2 times my daughter almost died were in medical transport. So granted, I have a little baggage around that particular issue. But what we're trying to build, and from a differentiation standpoint, is the ability to do those scans at the very front lines of care. And that requires just simply no ultrasound training at all to do those scans, which are screening level scans, based on a low-cost chip and sensors that support workflow sort of wherever the patient is at. So those same sensors offer a comparable resolution quality to existing gold standard devices. And you can see that that's like, that little wafer is about the size of my thumb, but those 4,000 microsensors are all individual drums. So we can program those lines to do more, which offers us the forgiveness we need for those unskilled users. It offers us scalability from a manufacturing standpoint so that we can get out faster to the places that's needed, and combating really the health inequities that exist right now in terms of access to ultrasound. So the AI software piece of the device is a separate pathway, so separate 510K pathway, and a separate layer, right? So what we can do with the automated image acquisition and remote interpretation is step 1 on our FDA pathway. And then step 2 on the FDA pathway is this AI clinical decision support piece. So we've already been able to make great advancements on where we're at with this, and we're using our own prospective data sets, which amounts to so far 460 newborns and about 53,000 images. So we also were granted our first primary utility patent in the fall of last year. That's a big deal for us because of what we have to do sort of next is to build upon that IP portfolio. So we have some provisionals already in the works, have already been submitted, and we'll work more on that internationally. And the initial customer acquisition pathway includes the high volume birth centers and really health systems that have community hospitals also under their umbrella and clinics. This is the 2-phase process I just talked about. We're rapid scan, we're rapidly in those sprint discussions with FDA for our 510K Class 2 device designation, and then the AI clinical decision support at 510K pathway will initiate towards the end of this year. These are the users we talked about earlier. Newborn screening is just one of those use cases, but primary care and low resource settings, emergency departments, and then eventually hospital to home, which is one of the studies we're doing with Cleveland Clinic right now. Existing reimbursement codes, we have identified 3 with future possibilities for a custom CPT code. And then our US go-to-market strategy is based on reaching 25% of our obtainable market in that amount of time. So I'm going to skip ahead just to my closing slide so that I don't go over time. But these are the PDCs we're working with already. You can see the overlap there on clinical sites, which are the little red dots. And so that's a really nice place to be, and we really feel very supported by the PDC network. So thank you for that. My daughter was in transport on this day many years ago from Minneapolis to Boston, and it's not lost on me that every child needs that same opportunity to survive and thrive. So I'm happy to take questions from there. Thank you for letting me go 30 seconds over.
I'll go first. Can I ask a question about, can you speak a little bit to the amount of clinical evidence that you need, not only for FDA, but to demonstrate adoption?
Yeah, sure. Well, because we're doing a 510K pathway, we're still in our second sprint discussion addressing the data needs. I think we provided a good chunk of what we had just as part of breakthrough. We weren't required to do that, but we wanted to show what we had in terms of matching image sets from our prototypes compared against gold standard ultrasounds. We want at a baseline level, we have to show that the resolution is equivalent so that not only a human could do that remote interpretation, but our ML algorithms can do that successfully. So I probably shouldn't say publicly since I'm a month away from having that call with FDA, but we're very clear on what we're going to propose in terms of the prospective data set that we'll submit to them for that hardware clearance. And it seems like a very, very clear pathway right now.
There's an online question.
Hi, Emery. Great presentation. Can you speak, to your commercialization strategy with going US first, and specifically what hospitals and networks you'll be targeting in the US and the value proposition to them with your two-staged approach, and then how that ties into pricing of the device?
Sure. So we decided with a US first strategy because it's in such direct alignment with our FDA first strategy. And that unlocks a lot of doors on the global health side. As you can probably know, I just spent last week in DC at the International Medical Device Regulators Forum. And all of that is about harmonization with your international regulators to make sure your device not only can be regulatory approved for deployment into those settings, but that'll actually be adopted into use in those settings. And as someone who's worked in global health for 12 years, that's clearly like a huge part of why we exist as a company and a huge part of the work. But the need is actually very critical for the United States. So I don't want anyone here to sort of think that we decided to take on the US first because it's a higher price point and it's more financial opportunity. That may be true, but it's not why we're going US first. It's just a streamlined approach. And I guess I didn't call them out specifically, but on that last side, Texas Children's, Children's National, University of Minnesota, and the work we have already started here with Impact One and the PDC, I think those are primary entry points. Boston Children's as well, of course, since that's my daughter's surgical hospital. Those are all umbrella centers. So those have been chosen as our first market entry points for beachhead in the United States. And we've tested not just the device, but the pricing model with those centers. So we're coming in at equivalent or slightly less than existing point of care ultrasound solutions. And I think that's where we feel comfortable being. And we've taken out that sort of SaaS layer of a lot of those POCUS solutions, which is the single thing that users hate the most.
Time's up.
Thank you so much.
Our next presentation will be IntelliStent.
Thank you to the organizers for giving the opportunity to present IntelliStent to you today. I'm really excited to be here and really proud to be here since I work across the street. I'm a pediatric interventional cardiologist at UCSF, and I'm a medical advisor for HeartPoint Global. I'm joined today via Zoom by two of the company co-founders, Seth Bogner, Chairman and CEO, and Dr. Hannah Ilshin, our COO. Congenital heart disease is the most common birth defect. Thank you to the previous presentation for doing a lot of that same shared mission statement. It affects 2.4 million babies globally each year. And unfortunately, the vast majority of them don't have access to early diagnosis or repair. And even the simplest of intracardiac lesions results in pulmonary hypertension if they're not repaired in the first couple of years of life due to the excess flow and pressure in the pulmonary arteries. To illustrate, this is a patient of ours at UCSF who had unrepaired congenital heart disease at 10 years of age. We were able to close his PDA in the cath lab, as can be done in most of the world, but unfortunately his pulmonary artery pressures remain systemic with a high resistance. And so at that point, there's two options to give the family. One is to say, there's nothing we can do. In that case, he'd become progressively blue and die from Eisenmenger syndrome in the next few years, or to try a risky treat and repair strategy with medications pre and post-op, accepting that he might not survive the surgery. The family opted for the latter, and he did well. It was a success story, but it's not the same for a lot of patients. They may not have access to those medications or specialist centers. And for them, another alternative would be a surgical pulmonary artery band, which mechanically reduces the flow and pressure to the pulmonary arteries. But that's an invasive open chest surgery, and it needs to be done multiple times if you have to adjust the flow. There's a really significant risk with that procedure, with published mortality rates of up to 20%, which is just simply too high to accept for most of our patients. And what I really want for that patient and for the many I have, multiple per week, who need flow restriction in the pulmonary arteries in our cath lab, is a transcatheter system that I can place and adjust myself. HeartPoint Global has designed IntelliStent. It's a groundbreaking multi-lumen stent system for the interventional adjustment of pulmonary blood flow. It's a groundbreaking innovation. It's not just an adjunct or an improvement on any existing therapy. It's patented with freedom to operate in every major market. And here's the components. There's nitinol reduction stents that are partially covered with a polyurethane coating to provide flow restriction but maintain patency to the critical pulmonary artery branches. If further flow restriction is required, those stents can be nested inside each other to reduce the flow and pressure. And if you want to reverse some of that restriction or even completely reverse the system, you can place a balloon expandable stent. The stent technology builds on existing delivery systems technology that all interventional cardiologists are familiar with, and therefore we expect early adoption when the IntelliStent comes to market. The system is designed to be placed in the main or the branch pulmonary arteries, and the system can be adjusted at any point in the initial procedure or at a later date to meet the changing needs of the patient. And this ovine example here, to prove it could be done, has 6 stents nested inside each other. The system has performed really well in preclinical testing in both an acute and chronic follow-up studies. The 100% success rate of delivery just really reflects the ease of use of the system. We were able to achieve pulmonary flow and pressure restriction with the first stent and then further restrictions with additional stents. And when desired, the interventricular septal position can be shifted, and that was maintained at a chronic follow-up also. And that's all without any thrombosis, damage to the valves, the vessels, or any other overt complications. As a minimally invasive transcatheter therapy with projected low production costs, IntelliStent can provide clear value-based care with the potential to save time, money, and lives, while also increasing access to care and reducing global inequality by providing a treatment pathway for patients with severe pulmonary hypertension from congenital heart disease. And just looking at that one market, the serviceable obtainable market for pulmonary hypertension and congenital heart disease globally is over 1 million patients. But IntelliStent can be used for many other indications as a replacement for pulmonary artery band. And just a very quick example in the pediatric cardiology space is for left ventricular dilated cardiomyopathy, where LVADs and transplants aren't available for most patients. And in that case, the pulmonary artery band can shift the interventricular septum, improve function and survival. So I've shown you the unmet need, our preclinical studies so far, and our current focus is on the first in human clinical studies and our pathway to regulatory approval. We believe IntelliStent meets criteria for breakthrough device designation, and we plan to work with the FDA with an adaptive trial design to meet the regulatory pathway. I see the time's up slide, so I'm going to go really quick. We have an upcoming clinical trial, and it's for older patient groups, and we would use any funding and assistance from this accelerator to do the downsizing of the stent components and systems. And there's our summary.
Questions?
So is this a class 3 PMA product? Is that correct?
Yeah, that's a great question. So when we've looked into it so far, between a class 2 and a class 3 PMA product, and our plan was to work with the FDA and try for class 2 and then wait for them to tell us why it needs to be class 3. But either way, we think there's a good pathway through.
Yeah, okay, but
Yeah.
one's going to be much longer than the other.
Yeah.
And then the last thing you said that I just focused on was you still need to downsize your stent. So it sounds like it's not sized well enough for pediatrics yet.
It is sized well enough for pediatrics. So looking at that age group of older children, for me, since a lot of my patients are babies, older children is 5 years plus. But to go to that baby, infant, newborn size, we'll need to get the sheath size down from what it is right now. And then the stent size needs to be sized for their pulmonary arteries.
Right, so basically from child size then to baby
To
size.
babies, yes.
Okay, got
Yeah.
it. Thank you.
And to be clear, you can see a path to doing that? I mean, funding's one thing, but you can actually see a technological path to doing that?
Yes, our CEO, Hannah Wilson's on there nodding away because I know that they've already designed and had kind of prototyped that that's going to be possible. And I also believe that because it's a stent system that we use similar stent systems that can be downsized.
What is the typical time in terms of the bridge to surgery component of this, and how long can this device stay in as the child grows, et cetera?
Yeah, so for that kind of patient example I showed you where they've got severely elevated pressure, it's going to be at least a few months, and you're trying to make them a good candidate to survive the surgical repair. There are other patients where this may be a destination therapy, where you're just trying to reduce the further decompensation towards Eisenmenger syndrome. It can be left in lifelong if it needs to be. It can be dilated as we do for all our patients. Now when we put stents in, we can go up and dilate them as they grow.
Elena, thank you so much. That was a great presentation. Quick question, in your clinical study, you showed that you were going to start with 12 to 17-year-olds there. Could you speak a little bit more about that, and then how you're going to limit your indication potentially in your breakthrough and your ongoing submissions with the agency if you're just starting there, or what's the thinking about that?
Yes, I think the initial kind of 5 to 10 patient selection, given that we have preclinically robustly tested that device size range, is what we're aiming for to get started. I think we want to roll this out to the earlier, to the younger patient groups as soon as possible. And so when we are putting the trial with the FDA pathway, we may write it as one big trial. And that's why we're talking about adaptive trial pathways. So starting it with that older patient group and then working down. Yeah. Okay, thanks.
So our next one is our neck breath test group presenting.
Great. Thank you all for being here today, and happy Ramadan to those celebrating. Fantastic. So I am Juliana Pearl, and I'm here to tell you about Exhalos, which is a breath test for necrotizing enterocolitis, also known as NEC. So NEC at its core is inflammation and a bacterial infection in the intestines of preterm infants. At this point, the core pathophysiology is not well understood, and we don't know how to catch it in its early stages. As a result, fear of the development of this condition in the neonatal ICU can result in the prevention of optimized nutrition for all 100,000 early preterm babies in the NICU. It can actually directly impact the 3,500 newborns that develop it, and it can have a death rate of up to 20%. So right now, how does this present? There's a series of subjective symptoms that can tip off clinicians. Now, these are feeding troubles, yet we know babies throw up all the time. It could be a distended belly, yet they're on respiratory support. So a concerned clinician will then take an X-ray. At that point, they may visualize tissue damage, at which point the damage is already done. They see pneumatosis on the X-ray, and they stop feeds, provide total parenteral nutrition, and antibiotics. Then, if the disease continues to progress, there can be bowel resection or even death. If there's no tissue damage, then you don't know whether or not the child is in early stage NEC or if they are healthy and you're just seeing these subjective signs, at which point you may have overtreatment with, again, NPO, TPN antibiotics, which carries its own risks. So we are developing the very first diagnostic for early stage NEC. This will be compatible with the multiple forms of respiratory support that you can find in the NICU, and it's based on hydrogen-based gases in the breath that are the bacterial metabolites of the bacteria at the root of this infection, and will be normalized to CO2. This is based on a hypothesis that's been tested in the 80s and 90s in a series of breath-based studies in relation to NEC. And we ran our own study in the Stanford NICU last year, where we caught 2 cases of NEC 1 to 2 days earlier than the X-ray diagnosis. So what you're seeing here in the graph, the red and orange lines were confirmed NEC cases via pneumatosis seen on X-ray. We see those spikes in hydrogen 1 to 2 days prior to that diagnosis with the dotted line in the middle, at which point the hydrogen levels drop at the start of antibiotics, showing that the gases you're looking at are likely tied to the bacteria at the root of this infection. The blue line is what we would consider an overtreated patient, where there was concern for symptoms, an X-ray was taken, they did not see pneumatosis, and yet they decided to treat the patient regardless out of fear of the condition. So as a whole, the study had 24 patients. We saw 4 hydrogen peaks. 2 of those were true positives. So if this diagnostic were in use, this monitor were in use, you'd be able to catch and treat NEC early, hopefully preventing progression of disease. If there were two false positives, which would have potentially resulted in overtreatment, 20 true negatives where you could have prevented overtreatment, accelerated the feedings for those kids, and most importantly, no false negatives. There were no missed NEC cases. We're hoping we could even improve upon those 2 false positives and sort them out further through the continuous monitor that we are now building, reminding this was once a day samples, very low resolution. So we believe that we can provide value to patients, clinicians, and hospital systems as a sustainable business. So on the one side, you have the value proposition of catching NEC early, preventing the cases of surgical NEC, preventing the neurodevelopmental outcomes that affect these patients. And when this device falls under the DRG payments, if you can prevent progression of surgical NEC, then across the board, you can save $3,000 per patient in that NICU, based on our initial health economics analysis. Then there's the side of rolling out NEC, where you can prevent unnecessary treatment and optimize growth. This gets us to market size of 130 million for the US each year, based on capital equipment located at the bedside in level 3 and 4 NICUs and disposable equipment for each patient. To date, we are still within Stanford University, and we have done everything with just grants totaling $100,000. We've run the clinical study. We've built a continuous monitoring prototype that's currently undergoing bench testing for a future clinical study. We're now part of, and feel very thankful to be part of, the Biodesign and Fogarty Invention Accelerator Program, and we filed our patents with Stanford. Our key milestones at this point will be the continuous study, multi-site. Our regulatory pathway will be pursuing breakthrough designation and the 510K clearance with the FDA. And this 100K will really be key for us in getting to that continuous study, finishing our bench testing, and building enough of these prototypes to get into the study to have on multiple patients at a time. Our team is myself with a background in mechanical engineering and healthcare business strategy. Christopher Strand is a senior research engineer specializing in gas analysis and mechanical engineering lab at Stanford. Janine Furch, serial entrepreneur and neonatologist. And James Wall, also pediatric serial entrepreneur, pediatric surgeon, and VP at Intuitive. Thank you very much.
Hey, Juliana, good to see you again.
Good to see you.
Focusing on NEC initially,
Yes.
do you see this as being, is there other use cases for this down the road? If you're able to do that kind of analysis of gases, can you see it being able to serve other needs?
Absolutely. Yes, I like that question. It is, so at the core, what we're doing, right, is there's bacteria in the intestines producing these gases. Those gases are traveling through the permeable intestinal wall into the bloodstream, out through the lungs. So at the core, what we're doing is detecting gases in the bloodstream. That has many applications. We think a core one could be sepsis. We think there's also the potential for ventilator-associated pneumonia and potential other cases as well.
Hey, Juliana, thanks so much for your wonderful presentation.
Thank you.
Curious, do you guys have any indication what would cause the 2 false positives?
Yes. So generally speaking, these babies are growing their biomes for the first time, right? It is possible that depending on the gestational age, when babies are preterm, every single organ's underdeveloped, right? Right now, these false positives are based on pure threshold values of hydrogen. We've yet to do the actual deeper statistical analyses and relate it to other elements of the EHR, whether or not they were on antibiotics, how old they were, these various factors. So at this point in time, the answer would be no, we don't know what those 2 false positives are. But the other difference is that right now we're just looking at these once daily samples of that threshold value, and we think that there's something in the rate of change. So when we look at the patient data, there appears to be a difference between these steep spikes that you saw in that graph and a slightly slower progression that we could see in these false positives. So with continuous monitoring, with breath being analyzed with every single breath cycle, we're hoping we can further differentiate those.
I was wondering, you'd mentioned overtreatment. Are there any consequences or side effects from overtreatment?
There are, yes. So if you think in terms of the objective ones, the delivery of antibiotics requires the insertion of a PICC line for central line access. So that comes with its own infection risk as well. Antibiotics is known to affect hearings, disrupt the developing microbiome. And for further ones, I, in the future, would direct those to our clinical team, but those are the key ones.
Great job, Juliana.
Thank you.
I think you came in under 5 minutes. Right there. So you spoke really fast. So kind of take it back to basics for
Sure.
me, because you said it sounds like standard of care is X-ray.
Correct.
And I'm assuming these babies are not X-rayed on a regular basis.
Correct.
And you're going to be doing continuous monitoring.
Yes.
So help me understand the workflow, the clinical workflow, and how this fits in. And if you have some early kind of adoption or feedback from clinicians of how they would incorporate this.
100%. So this would be screening, monitoring, right? So right now, the X-rays, as you said, are not regularly scheduled. When there is concern due to those subjective symptoms, sometimes I've had clinicians say it's because the baby looked at me funny. Like they have something in their the clinician's gut that tells them something's wrong with this kid. Let's take an X-ray. And there's also blood work associated too, where they look for inflammation markers and other things. But that is triggered by some concern for the child of unknown origin, and therefore that unknown origin could be neck because they don't really know. So that's what triggers the X-ray paradigm at this point. If they don't see anything on the X-ray, then they have to make a judgment call, do we or do we not treat this kid based on experience and gut instinct, and what else they might see in the blood markers. Now, what this would do is if there's no hydrogen and we have this really good negative predictive value, if that holds in the larger study, which we truly believe and hope that it does, then you might not have to send for that ultrasound when you feel like something's up for the kid and you can start the workup for other things that could actually be at the core of what's wrong, right? Now, if you do see a positive spike, we had these 2 over treatments in this study for the 24 patients. There were 7 that received in the 20 with no hydrogen, 7 of them received X-rays, some of them received treatment. So for those kids, you could just say, don't worry about it. It's whatever else is going on. If they do see a spike, then they can treat or start the X-ray and blood workup.
Unfortunately, that's the end of time, but thank you.
Thank you so much.
I'll just pause and say I'm glad I'm not a judge for these. These are all amazing innovations. Our next group, I believe I'm pronouncing it correctly, Pediarity?
Correct.
Okay, all right, good. Here we go.
Thank you.
Thanks.
Hi, everyone, and thank you for having me. I'm Jonathan, one of the co-founder of the company. And I would like to start by giving you a little bit of context. 7 days after birth, I almost lost my daughter because of a very strong virus. She couldn't tell what was wrong, and she ended up to the ICU. Now, a few weeks later, she's been discharged, and physicians were telling us that we should pay attention to some specific symptoms because a relapse would be possible. We didn't get any medical support, and we actually ended up going back to the ER at the time. Yeah, I did that correctly, cool. So that's when I realized that technology innovation was really lagging behind in pediatric compared to adults. And that really translates in macro numbers. More than 60% of the ER visits in children are not necessary. There are 10 times more preventable hospital admission in children than in adults. 40% of the kids have at least one chronic condition and it's on the rise. And every single year you have a crisis that is hitting all the hospitals and that saturates their capacity during the flu season. And yet, these problems are kind of solved already by digital health solutions in the adult space, but it hasn't really penetrated the pediatric market yet. As an example, you have 30% of all the home healthcare spendings that are dedicated to kids against only 2.4% when it comes to digital health. And that's why we decided to build the first comprehensive and customizable connected care platform to bring care to home for these kids. We are collecting data, health data, from RPM tools and also from manual entries. We have our proprietary product, but we aim to open the platform to some other product to expand populations. And we convert all these information into actionable information for providers. And on demand, we can even plug a command center to the system. The solution has been FDA cleared from 0 to 12 years old. It's been validated on over 700 kids with over 90% of adoption rate. We have 3 patents. And we overcome a pretty strong challenge, which is being very accurate on dark skins. We've been doing this thanks to a patented skin calibration algorithm. And the solution is GDPR and HIPAA compliant. The company is ISO 13485 compliant. And as a result, we currently have 29 paying customers. The mission of the company is to ensure the care across the entire continuum. And so we want to serve 4 different verticals. The first one is clinical study, which we've been doing for the last 2 years. Then we want to move to hospital at home, transitional care, and chronic care. On the clinical study side, this is where we currently have over 29 paying customers. But globally, we actually deploy those solutions across 40 different hospitals in Europe, in the US, and in Africa as well. Now that we have the FDA clearance, we are ready to expand to new verticals. And we are going to do that, with a very clear focus. The first one is going to be serving these acute respiratory illness patients. The second one is helping hospitals reduce the length of stay for NICU, with the first focus on NICU. And the second one is help parents and providers to regain control and maintain control of the disease, with the first focus on asthma. That's going to be an extra 7.7 million patients with a market potential of $4 billion. In terms of competition, we definitely compete currently with the current remote patient monitoring tools that are prescribed by providers, which are Covidien, Nelcor. These products are bulky, wired, they're not connected, and so that delay care responsiveness. But we also compete with these connected care platforms that are currently doing a very good job on the adult space, like Current Health, Bioformis. Now, when we talk to these companies, we learn that actually they don't do pediatric because there is a strong technological gap. There's also a different regulatory process. And finally, the go-to-market is different. So we've been investing our money to get the FDA clearance on all solutions so far, but also to build the clinical study business line. The next step for us is to get the pilot of the hospital at home to get into that new market. We have a very strong team, starting with Michel Lussier, our chairman, who's a successful medtech entrepreneur who has built and exited companies through IPOs and $1 billion plus exits. And then the rest of the team has a strong track record from renowned institutions, GE Healthcare, Carbon Health, Stanford. That's a few of them. We decided to submit to the PDC in order to get, with the hope to get the funding to run this economical study for the hospital at home. This is going to be pivotal for us. We already have the partner hospital. The protocol is under writing right now. The team is ready, but we're missing the funding. That step is going to be pivotal for us because it's not only going to help us to launch a new business line, but it's also going to help us to raise our next funds. So to wrap up, we have an FDA-cleared solution, business line that is currently bringing us revenue. We have traction on the new vertical. We're just missing the funding. And we believe that the UCSF Stanford PDC would be instrumental in helping us to achieve these milestones. So thank you for your attention, and let me know if you have any questions.
So great presentation, Jonathan.
Thank you.
A recent grandfather, a week-old grandchild, my daughter invested in Owlet, which pretty quickly made her the most paranoid parent on the face of the earth. Can you describe, do you see Owlet as being a competitor? Do you see that being a whole tranche of more data ingress for you? Walk me through how you see that.
Yeah, well, if you think about our monitoring tool, you could see them as a competitor, but that's not what we do, right? What we do is a connected care platform that really helps the hospital to expand their capabilities beyond hospital walls. And that's what today interests hospitals. So we currently have our own monitoring device, which is actually FDA from 0 to 12 years old and not only from 0 to 18 months, right? And when there is something wrong, well, we support the parents through the connected care platform and the medical team that is behind it, where Owlet is just alerting when there is potentially something wrong and drives people to the ER, right? So we're not in the same place, right? That answers your question. Okay.
Sorry, great presentation. Thanks, Jonathan.
Thank you.
Just quick question. Are you RX or OTC? Are you a prescription device?
Prescription device, absolutely.
Okay,
yes.
thank you.
Wendy.
Yeah, thanks. Thanks for the great presentation. I'm having a hard time understanding. I understand early NICU discharge. Can you help understand, since viral infections are unpredictable in typical families, how these would be deployed and when they would be deployed? Like, I just don't quite understand that model for the well population.
So we don't address the well population. We help acute respiratory illnesses once they came to the hospital, and then we don't know what to do. So we basically help the hospital to manage the flow of patients that's hitting them during the flu season. So we can follow them at home instead of giving them some beds where maybe their level of criticality is not like as high as some others. And so we just try to avoid hospital to get saturated. This is where the interest from the hospital is.
Yeah, thank you. And can you, besides oximetry, what other data is being collected?
Heart rate, SpO2 are the two that we are collecting now. Movement is something else that we have. We have respiratory that's been developed, which is going to be added in the coming year. But we want to open our platform to some other devices. So we currently have discussions with temperature sensors, potentially glucometer as well. So that's where we're heading.
Thank you.
Of course.
Yeah, I have a great presentation. Thank you so much.
Thank you.
You mentioned that there was 90% adoption of providers and patients. Can you elaborate a little bit to
of course.
that?
Yes.
And then also, are you currently generating revenue? I might have missed that.
Yes. So We run a study on over 100 kids, multicentric, 2 care centers here in the US, Columbia and Children's Now, and 2 others in Belgium, which is where the headquarters of the company is. We monitored kids up to 3 months, and that was indication agnostic. So we had essentially actually cardiac and respiratory issues. We had a few acute, but essentially chronic. And the objective was to assess whether parents would use the device and whether physicians would actually like to have access to these data. And so that was based on questionnaires. And so the rate is basically their answers. So we're ranging from 93, 96, 95, and 99%, depending. We had 4 questions around that. Regarding the revenue, we are generating revenue. We've got a very small 40K in 2022. We went from 40K to 400K last year, and we keep growing. But now the team is kind of too small to actually take more, and we have some other verticals that we would like to to address. So.
Great. Thank you.
Thank you.
So much.
We're halfway through these amazing presentations. We have 5 more. Our next company will be Nayada from Monier Corporation.
On the keyboard? Oh, okay, great. So I'm Mo. Thank you for hosting this. I'm the co-founder and CEO of Monier. We're building a software as medical device for detecting anemia from eyelid images. Anemia is a silent killer. It's a dangerous condition of having low hemoglobin in your blood. Extremely common among children, and you can see the numbers worldwide, how they are affected. 2 billion people are affected by anemia altogether. Oh. CDC and WHO, World Health Organization, they have programs worldwide, including United States, to monitor and manage anemia surveillance all over the world. So 20% of USA kids can have anemia one time or another in their lifetime. So, and if you go to the global numbers, it's about 60 to 78% in the other countries. So this is forcing our future into a cognitive disability and a lethargic lifestyle that cost us GDP of $4.2 billion yearly. Anemia is also linked to childhood obesity and depression. As you can see that it has the applications in different sections of our clinical sites, like where the higher insurance cost, like 50% higher, 1.5 times than patients that have anemia and that don't have anemia. And having anemia can upstage the cancer or CKD conditions, which can lead to fatality. So big challenge translate into big commercial impact, commercial opportunity, and also global impact. So we are integration ready, and we can be implemented with wellness applications, including pediatry. The last pediatrity, we can integrate with them too, with the at-home monitoring or at point of care monitoring. So the current standard of care is CBC test, the lab test, and at the point of care, it's HemoQ, the hemoglobinometer. Both of them require blood pricking, needle pricking. Study shows that 6 out of 10 adults actually do not do any testing because they fear needle pricking. And I'm sure children are not fan of that either. So we are non-invasive, and we are also painless, that's why. And we're real time. We give the results in 30 seconds. And we actually built this application based on our AI foundation model that was trained on 81,000 of data that's been created from our partner hospitals all over India. So this is the standard of care right now. It takes time. There's no tracking inbuilt into it. The future is supposed to be real time, non-invasive, and inbuilt. So I'm going to show you that how we do that. So we have an MVP ready that's being used and tested in separate hospitals and pediatric centers. So you log in and you take picture of your both eyes. So I'll just take a photo, selfie photo. You just take a photo like this. And it connects to our algorithm of the AI platform in the cloud. And then it gives you the results. Yeah, it's not seeing it. Okay, I'm wasting time. Give me a second. Okay, so I'll test all of you probably after this. So this has a unique appeal to pediatric population, being not speaking and not crying. And they are not crying when you are using this. It has no medical device, no biohazard, and we have a great set of data sets. So we are the trendsetter in this market. This is our business model. We are going through wellness industry, preventive care, and medical care. So we're ready. Okay. So we are integration ready. So we can integrate with other platforms, and they can use our own app too. We are only 1 year old right now. So we have had that multimodal AI platform, and we have filed our patent. And we are working with these children's hospitals and AIAMS for our clinical study. Our FDA clearance pathway is 510K. We are going on HemoQ and Massimo, SPHB, non-invasive hemoglobin measurement. And this is our intellectual property protection, proprietary multimodal dataset. We have a patent filed, and we have our trade secret. So we are working with Brown and Columbia University for doing some clinical trials here. And we have a New York community, Georgian Community Medicine Center for testing our app. Beachhead market is, beachhead market is India because we didn't need the FDA approval for that, and it's quick to get into. India actually needs this. There's like 600 million people that has government program to monitor anemia, and most of them are kids. I'll not go through this right now. And we have 27 Monerian, and we have Dr. Chuma. She has decades of experience in public healthcare. And we're raising pre-seed right now. Sid.
Wendy Sue.
Hi, thanks. Thanks for the great presentation, and look forward to another demo. Just wanted to ask quickly, are you doing clinical validation on both infants and toddlers?
Yes, not infants, but toddlers. So we are working with Institute of Children Healthcare in India to do a clinical trial right now. And in the Georgian community centers, they are also testing as a research use only application.
Thank you.
Thank you for the presentation. If you were to win an award today, what would the funds go to doing?
Yeah, our funds will go into first FDA clinical study, and then hiring a few engineers, because we see some challenges as you take the picture and do the hemoglobin estimation, because even if it doesn't depend on your color, skin color, there are different physical structure for eyes. So how they will come up, what's the ROI that getting it. So we need that challenges to be handled. There's also 7 to 10% of data that doesn't have clear connection with this empirical knowledge, which is that your eyelid actually reflects the hemoglobin. So we are seeing in our about 85,000 data that there's 10% data that doesn't reflect that. So definitely there's some medical history connections. So we are collecting other medical histories so that we can find that challenges that into 10% data, and we can maybe we'll have finding some evidence of scientific evidence in there.
Can you explain the business model a little bit more?
Yes. So the business model is, first of all, it's an integration ready product. So we have an API. So we are talking to other monitoring applications that does not have hemoglobin monitoring, because the hemoglobin monitoring that exists right in the market is invasive. It doesn't come with the monitoring parts, and also the Massimo one, it doesn't have any integration with any other applications. So that's first. And then we have our own app also, so people can use that for at-home monitoring there. And in US, we are working with the reimbursement code professional to figure out like what the CPT code would be. It feels like we can ride on the Massimo one and the Hemoki one.
So would it be a per test fee or a subscription?
It's a subscription model. That's what we prefer to go. It's a software as medical device, but it will have some tiered pricing model, like depending on how many you do. In India, it's average contract that's coming to us this year is about 75K, and that's for 3,000 people all over the year, and it's like 4 tests in a month. That's actually recommended. So based on that, and there's like 600 million people. So we are doing now pilot in one of the state government schools for adolescents, girls mainly, and that's 6,000 students, just one district, 6,000 students, 4 tests in a month, and that's under paid pilot right now going on.
Thank you so much. Thank you. Okay, our next company is Durek.
This one? So good morning. On behalf of our innovation team here at UCSF, not a company, physicians here at UCSF, I'm presenting on a device we call the DREC, which is a sensor that measures intracranial pressure, and it's meant to be incorporated into a device called a ventriculoperitoneal shunt, or VP shunt. That's the most common implant that we use as pediatric neurosurgeons. So historically, measuring intracranial pressure has been isolated to the ICU, and what this device would allow would be for us to measure ICP in the ambulatory outpatient setting. It would also allow us to reduce or even eliminate the need for invasive diagnostic tests, and probably most important, it would facilitate our ability to diagnose shunt failures and potentially the emergent need for shunt failure surgery more early. So what's a VP shunt and what is it treating? So the most common diagnosis we treat is hydrocephalus, and this is an imbalance in the fluid in your brain and spinal cord, the cerebrospinal fluid. And so when CSF is building up in your head, so too is the pressure. There are many causes of hydrocephalus, and the primary treatment is this small tube and valve system that connects the ventricle of the brain to the peritoneal space of the abdomen, or the ventriculoperitoneal shunt, the VP shunt. Shunt surgeries are frequent, and hydrocephalus is common. And unfortunately, the failure rate of these devices is exceedingly high, and within 2 years, half of these implanted devices have already failed. One of the most troubling things for me as a pediatric neurosurgeon is that once I implant one of these devices, I have absolutely no way to communicate with it directly. And this represents a diagnostic dilemma, because if the patient comes in shunt failure, it's sometimes difficult or even impossible to diagnose that failure without the need of invasive diagnostic tests. And this has been the case for the 100+ year of history of VP shunts, our inability to communicate directly with it, and we're in dire need of change. So with an inability to directly communicate with the VP shunts, this is our algorithm, and these are alternatives to that, which are helpful but have their shortcomings. We can clinically assess the patient, but I work with pediatric patients who are unable to fully elaborate their symptoms, or maybe they're delayed, or we have language barriers. We serve a diverse population. And so it's difficult sometimes for clinical assessment and physical exam to know what's going on. We can image the patients with a CT scanner and MRI, but CTs have radiation, and MRIs have a need to lay perfectly still and therefore potential need for anesthesia. And a huge problem is that not all VP shunt patients increase the size of their ventricles, so we're even getting scans of patients who might not reveal a difference in time. We can insert a needle into the shunt and aspirate some spinal fluid or inject a radionuclide, but every single time you inject these devices, you can introduce bacteria and create an infection, and the sensitivity of these devices is not very great. And the last resort, of course, is just open surgery. I'm taking a patient in the operating room, and there's nothing more disappointing than to take a child to surgery to find out that actually their shunt has been working this whole time. So we've organized this in a continuum of invasiveness, and the DIREC lives in this space here. And we feel this is a huge leap forward in the evolution of how we evaluate shunts, gaining a significant amount of information with a low amount of risk. The proposed value is that we would simplify the evaluation of the shunt, reducing the cost of how we assess them and how we intervene in them, and hopefully prevent unnecessary surgeries. The estimated market for shunts is $300 million, for domestic hydrocephalus $1 billion, and global hydrocephalus $2 billion. And this is the actual device. It's small and wireless and batteryless. An electromagnetic wave is activating a device, which then converts that wave into electricity, and then we measure intracranial pressure. That number is transmitted to a handheld device. This is a prototype of the device. It's a centimeter in dimension. It's important to note that this device is completely MRI compatible. It's so hugely important for our VP shunt patients who are constantly getting MRIs as part of their evaluation. So this is a schematic of our proposed new device, which is smaller in dimension. It's in continuity with the shunt. It's in contact with spinal fluid in a silicone reservoir. And it's important to note that one of the earliest prototypes of this device has been in continuous monitoring phase for 7 years with no measured shift. That's a huge problem with implanted sensors. We're working off of technology with 2 patents. This is our proposed milestones and regulatory path, going from device miniaturization to animal studies, 510 clearance, and then human clinical trials. This is an important step because in the pediatric population space is at a premium. Scalps are very thin and they're fragile, and bulky devices open up wounds and get infected. So the actual award from this competition would be used to miniaturize this device to the smallest possible parameters. In terms of the landscape of what devices are available to actually to monitor shunts non-invasively, there are very few products. And so I've listed some of the features here and the advantages of the DIREC. And as you can see, the competitors share some of these features, but don't possess them all. We believe there's a reimbursement strategy using these CPT codes. And if we follow our regulatory pathway as planned, and as we're selling more units and our revenue increases, we think there'll be an inflection point approximately after 3 years so that the device becomes profitable. This is our team. Thank you very much.
Open up to questions. Emma.
Thank you for the great presentation. I have a question on the technology and device design. How does it face with the shunt? Is that something that needs to be done at the manufacturing level, or can it be done, at the operating table as you're doing the surgery itself?
It's a very small component, and once it's miniaturized, we can actually approach it in either way. Personally, I think the easiest way is to actually incorporate into readily available components of the shunt. And shunts are kind of an a la carte menu for surgeons. You pick and choose the parts that you put in alignment. So at any point along the shunt system that's in contact with the spinal fluid, you can insert a device that's either part of pre-made manufacturing hardware already available, or something that we have as a standalone device.
So to that end, do you plan to sell shunts or sensors that anybody can apply to any shunt?
Sensors.
So building on that question, I noticed in your write-up it talks about 24-bit resolution on the pressure monitoring. So it's a highly accurate pressure monitoring device you're putting in there. Do you see other use cases for this inside the body?
Well, actually, one of the predecessors of this device, and one of the reasons why we went with this approach, is that an actual sensor that is measuring intraocular pressure, which is even smaller than our proposed parameters for our VP shunt, which is why we think that 5 millimeter proposed parameter is achievable.
Wendy?
Yeah, and just to understand, so this is home monitoring. So just symptomatically, if a child developed a headache, then mom would take that external piece and get the measurement. It's not continuous, right? It's used with that external monitor.
Well, actually, excellent question. Actually, I think probably what makes the most sense is upfront, we as clinicians in the ER or in our clinics who have suspicions would be the first pass at this, and we would have it as a clinic tool. But absolutely, ideally, I think the reason why families are so excited about this is that if they could have a box of these on the shelf at 2 o'clock in the morning when they're wondering if Johnny's headache is real or not, they can use this device non-invasively at home. That would
Yeah.
be the version of this.
Yeah, amazing. Thank you.
Any other questions? Thank you so much. Okay. Our next presenter will be CNIBP. Elena. Perfect.
Thank you so much for having me. My name is Elena Rajagopal. I'm the co-founder and chief medical officer at Esperto Medical. So as a mother, one of my worst nightmares is taking one of my kids who's critically ill into the hospital where I work and watching my colleagues place a bunch of lines and tubes in their little bodies. As a physician, my worst nightmare is not being able to get the information I need from all of those lines and tubes in order to make the right clinical decisions. Unfortunately, this is a reality in pediatrics. Blood pressure is really difficult to measure. Blood pressure cuffs are inaccurate in children with about a 14 millimeter mercury inaccuracy in systolic blood pressure, which can be all the difference when your patient's normal blood pressure is 80 or 90 systolic, in whether you would classify that patient as normotensive, hypotensive, or hypertensive. An alternative to that is the arterial catheter, but unfortunately these come with a risk of a lot of complications in up to 10% of pediatric patients. Some of those complications include being more likely to die than those without complications, being 4 times more likely to experience systemic infection, or 6 times more likely to experience limb amputation. So these side effects are really unacceptable for our most vulnerable and tiniest patients. There's a host of different technologies that have been developed to try to address this gap between a continuous, accurate, non-invasive, calibration-free device that can be used on any artery. And until Esperto developed our method, none of those were able to address all of those different metrics. So our method is called resonance sonomanometry, and it's based on first principles physics and an ultrasound. And basically what we use is a sound stimulus through a bone conduction headphone that then induces a resonance in the skin of the artery. That resonant frequency is then mathematically relatable to the internal pressure in the artery. And so through that, we're able to get a directly observable, inference-free, calibration-free measurement that doesn't require any input of demographic characteristics. So the solution we're proposing is our first product, which is an armband. And like I said, it's based on first principles physics using ultrasound, which is a very safe, well-known technology. It's calibration-free, continuous, non-invasive, and plugs into any existing hospital equipment to help ease adoption. It also can be used without a monitor for patients who need to transfer for imaging studies or to use the restroom, for example. It can also be placed by any medical professional in under 2 minutes, so should be as easy to place as a blood pressure cuff, and can be used most importantly on any artery visible to ultrasound, which would allow for both central and peripheral monitoring of blood pressure. This is demonstrating the arterial waveform from the brachial artery on the left and femoral artery on the right. The gray lines that you see are from a blood pressure cuff, and so it demonstrates good concordance with existing methods. So the focus of this grant or request is to take our first product, the Esperto armband, and begin testing for pediatric patients ages 12 and up, with a plan to then test ages 12 and under beyond that, and then to continue to miniaturize the device for smaller and smaller patients down to a neonatal. Our value proposition is that we're better for patients because we're safer and more comfortable. We also empower providers by getting them more information faster with advanced physiological metrics and on any artery. It's also cost savings for hospitals by increasing throughput and also can reduce the cost of complications, which can be significant. The market is large with a total market of over $20 billion. We intend to first go into hospitals and outpatient clinics, then into remote patient monitoring, and finally consumer health tech. Our regulatory plan is as a Class 2 de novo device. We've already completed a PCI meeting with the FDA, so thank you very much to the PDC for helping facilitate that. We have also completed our first pre-sub meeting and plan for our de novo submission in 2025. Our reimbursement will be through DRG coding, and we have significant intellectual property with freedom to operate. We're asking for $100,000 to do a feasibility study in adolescent pediatric patients 12 and up, pursue additional regulatory consulting, and then to do additional prototype iteration and testing for younger patients and smaller devices as funding and evidence supports. Today, we're working on completing internal validation of our Proto 3, so our pre-product prototype, before starting our external clinical studies, and then also planning to file a breakthrough device designation once we finish that internal testing, moving into our FDA trials in early next year. This is our team. The technology was developed out of Caltech, as it appears most of our team was as well. We have significant experience in ultrasound, mechanical and electrical engineering, regulatory applications, as well as pediatric devices. So with that, I'm happy to take any questions.
We'll start with Avi.
Hi, thanks for the presentation. Can you talk about work you've done to assess movement-related impact to the readings from said blood pressure cuff?
Yeah, so this is something we've had a big focus for the last 6 to 8 months. Many of the existing blood pressure devices are placed on a finger or on the radial artery, and so we've identified this as a problem for blood pressure monitoring, particularly continuous blood pressure monitoring. So we've been developing algorithms so that the software is able to autonomously locate the artery and then track and lock into the artery over time with movement. So we're using algorithm-based developments to be able to account for those movements. And additionally, we take a measurement about every 10 milliseconds. So our measurements are faster than the rate at which tissue moves and biology moves. So we're able to account for that.
Thanks so much.
And along similar lines with the technology, when you talked about scaling it to smaller pediatric populations or putting them in different locations, is that mainly on the software and algorithm side of development, or is there hardware that needs to be changed for those different applications as well?
Yeah, that's a great question. It's probably more based on hardware. So right now, we have a device that's maybe about the size of like an iPhone. And so we want to be able to miniaturize that so that there's less real estate taken up on smaller and smaller bodies. In order to do that, we need to do ASIC development. And so that's a fairly expensive undertaking. So that's kind of what our plan is, as far as making sure that we can take measurements on some of the adolescent patients first, and then continuing the process of miniaturization with that development into smaller and smaller devices. But there's not really a limitation into why we couldn't take measurements on smaller patients now with the existing technology, other than sort of ease of use and comfort.
You sit.
I was just wondering, I noticed you had the slide comparing what some of the competitive devices are, and I couldn't quite see on some of them why yours would be competitive, because some of them also looked like they were wearable.
Yeah, so there are a lot of devices that have come out recently that are wearable in the blood pressure space, but none of them take an actual blood pressure. They're all taking a relative blood pressure. And so they require a calibration to a blood pressure cuff or an arterial line. And the further out you are from that calibration step, the less and less and less accurate they become. So that's sort of the major advantage of our device, is we're taking multiple measurements every second. And so because of that, it's always a direct measurement, and it's not moving away from that calibration point. So we have increased accuracy. Additionally, most of those tools are only available to sort of superficial arteries, like the radial artery or the digital arteries. And so that again limits the sort of movement issue, as well as the ability to take central blood pressures.
One quick question then. You just mentioned you're pursuing ASICs as being the possible path. You haven't looked at GPUs. ASICs are incredibly expensive to own and operate.
Yeah.
So the GPU can't do them. I mean, off the market GPU?
I would have to defer that question to our engineering team, but they have miniaturized devices in the past doing implantables in fruit flies and mice. And so they have identified the ASIC as probably the best pathway forward, but I will ask about GPUs.
Thank you so much.
Yeah.
Okay, great. Our next presentation is VPS Encore Peds.
Hi everyone, is this the clicker? Oh yeah. Okay, not the clicker? Clicker works. Yeah. Hi everyone, thank you. I'm Rafael Veraza, the CEO of Vascular Perfusion Solutions. We're super happy to be here, and it's incredible all the companies we're honored to be here with all these companies trying to save lives. We are a small company out of Texas developing organ preservation devices. Our main device for adult population. We learn a lot on that device, and now we're asked, and the company make the decision to actually pursue a pediatric device. So in pediatric transplantation, there's about 100 children that die every year waiting for a life-saving organ. There's about 500 transplants currently in the United States, a small population. And there are about 800 patients added to the wait list almost every year. And there's also a huge discard of hearts. The utilization rate in the United States for adults is about 30%. In pediatrics, is even lower than that. And the fact is that the pediatric patients waiting for a heart or a life-saving organ, specifically for hearts, they're actually the sickest out of all the patients. A lot of these patients are in status 1 compared to the adult population. And one of the biggest barriers in heart transplantation, not only for adults, but also for children, is that for the last 50 years, we've still been using the same technology that you used to do basically to keep the catch of the day, the cooler. The cooler only can keep a heart alive for about the most 6 hours. It is demonstrated that if you keep the heart in the cooler for longer than 6 hours, the survival of the patients goes down dramatically. And in pediatric heart transplantation, you're talking about surgeries that go between 4 to 12 hours because of the congenital heart reconstruction that has to happen in the recipient. So in pediatrics, it's even critical to be able to have a device or a system that can preserve the heart for longer than the standard of care. So we developed a very simple system. It's a hypothermic perfusion system. What it does, it keeps the heart pumping with solution. Crystalloid solution is off the shelf. We oxygenate the solution and keep the cells alive. In our studies in our lab, we kept hearts viable for up to 24 hours. The device is 2 components. It's a reusable transport case, and a cartridge is basically where the heart chamber is located. It's portable, simple to use, and then the idea of this device is really prolonged heart preservation. We have 8 patents on file. And another ideal situation with devices and be able to keep those hearts alive is lower pressures that are gentle to the physiology of the heart. We've done some tests in our lab. We preserve pediatric hearts of as small as 65 grams. The ideal situation of miniaturizing our components and our device is really the cannulas. A lot of the cannulas have to be very miniaturized to ensure that you can deliver enough pressure to the system. Those are the different versions of our devices. Now we have actually a clinical device that has been tested. In the pediatrics, the money that we'll be actually requesting, and we're fundraising for that, is to miniaturize the canister and then start the experiments in our lab. This is a study done in our lab. Basically, we preserve a heart for up to 6 hours and then place in a system called a Langendorf that rewarms the heart, and we're able to get really interesting data and good contractility after preservation. There are other players in the market. There's the standard of care, the cooler. There is Paragonix. All of them don't have a pediatric device, and our device basically address the pediatric population. So, like I said, there is a high waste of hearts. Only about more than 70% of hearts are wasted, and the surgery time goes between 4 to 12 hours, and the cost to the patient is about $1 million for heart transplantation. This is our timeline. We raised about $500,000 to continue studies in orthotopic heart transplant studies. We have a really good dedicated team with product development, engineers, and actually FDA consultants that have actually played a role in developing this device and approving them, and a great scientific advisory board. And we have great collaborators such as Duke Joseph Turek. He's one of the first transplant surgeons that did a partial heart transplant. And the request to actually develop this came from him. So with that, I'll open this for questions.
Do you have any IP on this? Maybe I missed it.
Yes, yeah, we have eight patents filed. Mm-hmm.
Can you talk through workflow just a little bit in terms of, I would imagine you want to keep this heart in the preservation container until you need it because the surgery is multiple hours. What does it take to get it out of the chamber and ready for implantation? How long does that take, and can that also lead to ischemia?
Yeah, so so the heart is cold, hypothermic. It's basically removing the lid, removing the cannula, and basically while there's in surgery, it's still in the system being perfused. But once the chest is ready, they have removed the other heart. The chest is ready of the patient. Is literally there's a zip tie. We can do zip ties, or you can do an umbilical tape around the aorta. There's enough room basically to ensure that there's enough aorta for the surgeon to continue to suture that. Remove it, flush it, and then that's it. It's pretty simple. Yeah, there's no major changes in workflow. They're already doing that for other devices, and yeah.
Wendy?
Yeah, thanks for the nice presentation. I saw the differences in your graphs, which are extremely stark between, pediatric versus adult. How many children die on the wait list, and I understand that that's likely very multifactorial. What percent of children who die on the wait list don't receive a heart because of ischemic time or because of time to transplantation? I mean, how much of the problem is the problem that the area that you're solving?
Yeah, our chief scientific officer is here. She might be able to tackle that question.
Yeah, we try to look at the, kind of strategize those, the ischemic times versus other reasons. Based on some published papers, we think it's around 60%. But this is based on the literature, basically. On the published studies, it should be around 60% of those that go beyond ischemic times, and the heart is not being implanted on time.
Thank you.
There was a case. Oh, sorry, Jim. There was a case that we work with Dell Ascension in Austin, and there was a case of a 7-year-old heart that was in the cooler for over 9 hours. That was transplanted, and then after transplantation, I think the boy died after 2 months. Not necessarily because of the transplantation, but that's just a case of the surgeons telling us, hey, look, if we have a device that can keep the hearts longer, then we have peace of mind that we're not running out of time on that ischemic time, on the heart being in the cold static storage.
Maybe on the same line there, I noticed that you had for your pathway to market a HDE, I guess.
Yes.
So you're starting just within the heart, the organ, but can you speak a little bit more about why it's HDE, and then where you might expand to other organs?
Yeah. So for the adult, we're a PMA class 3 device. That's said. But for the pediatric, we're being advised, and we've been talking to some consultants. It's a small population, right? We're addressing the humanitarian device exemption, the humanitarian use device is specific for a device that can address a small population. That's our thinking there. We're hoping through the program, if we get selected, we're able to have actually direct talks to the FDA about this. Yes. Mm-hmm.
Your consultant, right?
Yes. Oh yeah, you know Ben? Oh great. Yeah, he's great.
Okay, thank you.
Thank you.
Great, thank you so much.
Thank you.
Thank you. Okay, and our final presentation will be TPN 2.0, and Nima Isramo, who you see here. Take it away. Thank you.
Hello, and thank you for having me. I'm Nima Gaipur. I'm the chief scientist for Takeoff AI and an associate professor at Stanford, where I run a lab of AI and ML scientists primarily focused on maternal and child health. I don't need to explain to this audience that infant mortality has been rising, including here in the US, across the board, also in LMICs, and NICUs are our first line of defense against this. We recently published a paper on the cover of Science Translational Medicine where we showed that using electronic health records and AI, we can already predict various diseases in newborns. This baby, for example, got sepsis at 1 month, they got BPD, they never got neck or cerebral palsy. We predicted all of these accurately, but importantly, we predicted them a couple weeks before the baby was even born. And then the question was, how are we going to commercialize this? This went through the biodesign program at Stanford, and we quickly learned that just making predictions is never enough. The AI has to be actionable. It's not enough to say, this is what's going to happen to the baby. We have to put forward the way for fixing it. Otherwise, because of physician alarm fatigue and other challenges, it's not going to be taken up by the healthcare system. So instead, we give the AI away for free, but we use the AI to sell interventions to the hospitals. Our first intervention is focused on total parenteral nutrition. When a baby is born prematurely, sometimes they don't have the gastrointestinal system to process breast milk. So instead, you have to put them on these IV bags. The challenge is that what goes into the IV bags is reactionary. They basically say, hey, looks like your sodium level is too low. Let me give you more sodium for tomorrow. It's also expensive and needs a complex infrastructure. A neonatologist places an order, a dietitian calls them because they don't like something about the order, then they fix it and submit it again, then the pharmacist calls them because the osmolarity is not right, and keeps going on until they eventually submit the order successfully. The pharmacy has to make it in a sterile environment, ship it to the hospital overnight, and you have fulfilled one order for one patient. You have to keep repeating that for all the other patients. Also, TPN is the single largest source of error in the NICUs. Year after year, this has been shown by the Institute for Safe Medication Practices. So it's also not just a source of error, but it's a source of error with significant consequences. So we deployed our AI algorithm, which knows what is going to happen to these patients several months down the road, to write these TPN prescriptions based on objective long-term data. And in doing so, we showed that not only we can increase safety, but we can also reduce costs by 80% because we can anticipate needs and we can mass manufacture the TPN bags in advance instead of making them one at a time. Of course, these are big claims to make. We have done several studies. I will show you just one of them today. We took 180 patients at Stanford and we did a blinded test where we showed the real prescription and the AI-generated prescription to a number of physicians. And we asked them to do a chart review and tell us which one they think is a better fit for the patient. This is Gary Kasparov playing against AI. Many years ago, I was a little kid watching this live. It was the first time that humanity was losing to AI in chess, and his body language speaks for itself. I'm going to show you a spontaneous photo from our first pilot, and from body language alone, I'm sure you can tell which one is my neonatologist friend, which one is my AI friend, and what the results were. But the bottom line is that they can't tell the difference between the real one and the AI-generated one. In fact, they pick the AI-generated one as the one that they think is a better fit for the baby than their own. We have done now several other studies that I don't have time to go into. Going straight into market size, there are 3.8 million pregnancies in the US annually. 10 to 15% of them end up in NICUs. And NICUs are the largest profit centers in US hospitals. The average pregnancy costs $5,000. An extreme preterm birth case in the NICUs quickly reaches up to $500,000 and more. The unit economics of this are also very interesting. Every AI company's dream is to one day have a reimbursement pathway. TPN has already been getting reimbursed at $600 per day, and the kids stay on TPN for about 12 days on average. We can reduce the cost of TPN through mass manufacturing to $50, and that quickly gets us to a bottom-up financial model of about $5 billion in SAM, and the total NICU SAM is about $70 billion. This is a project that wouldn't have happened without lots of mentorship from Stanford Biodesign, Ignite, StartX, Spark, and other places. We just closed our pre-seed round last month. It was oversubscribed, and it's led by some of the venture firms in the Valley that you have heard of. That is going to take us through our IP licensing from Stanford. OTL owns the patent, and we are working on licensing that, getting our software as medical device clearance by the FDA, and a study that we are soon going to run at Stanford. This is extremely well aligned with the PDC accelerators expertise, because we are going to go through those regulatory steps. But we have a pretty good understanding of what needs to happen, and we already have most of the data that they are going to need for that. And that will take us to our seed round shortly. But the vision behind the company is larger than that. When you're born, you're weak, you gradually get stronger, you age, you die. End of life care, as you all know, is a poor investment. We want to use AI in the first few weeks of life to push people to a higher level of health. And our AI knows what is happening to these patients in the long run, so we can react early. TPN is just the first opportunity. There are lots of other products that we are working on in the first few weeks of life that will be guided by AI to optimize health in the long run. Thank you.
Good job, Nima. Questions? Avi.
Yeah, just to focus on the TPN, because I'm originally a mechanical engineer, so apologies if this is naive to the group. How many components, like just roughly, is it 3 components in the TPN? Is it 5? Is it 20 in terms of, sodium, sugar, whatever? How many things are you trying to optimize?
Yeah,
About
20.
what?
20.
20, okay. Thanks.
I'm curious if there's anything proprietary in your TPN formulations and its stable shelf life? And if so,
So it's stable for 2 years at room temperature as long as you store it in a dark environment. And that's critical because if you need to refrigerate it, good luck getting space in NICUs. But we are very glad that that one is resolved. In terms of whether the compositions are all very standard, there is nothing new in them. And that is by design. We have designed them to be standard because it will make our FDA clearance process much easier. It doesn't have to be classified as a new drug and require RCTs and so on. But we do have products that have non-standard ingredients in them that are designed for preventing specific outcomes. But that is something that we will tackle later in the life of the company. For this first product, everything is a standard. It's not going to require its own RCTs.
Emma?
Wendy, so you go first. Thank you.
Oh, yeah. Sorry, I'm actually a bit confused. So it's both that the company is based on the forecasting of what the formula is for each individual baby, and then you're manufacturing TPN as well. And as I reviewed your application, I remember there being like 15 different formulas or 15 different standards. How many iterations of I thought there were many more different kinds of TPN that you could calculate for the different I'm just not a neonatal, I'm a pediatrician, but is part of the AI and the learning that you've done by decreasing the different number of formulas?
That's exactly true. The AI looked at 10 years worth of TPN at Stanford, and it said, while it's true that you write this from scratch for every baby, and it's a little bit different, as long as you have these 15 that are designed by the AI, you don't need to start from scratch every time. You can just use one of the 15 and it will be as good. And then we ran a pilot with the physicians and we showed that they agree. In fact, they prefer one of the 15 to their own.
So in some ways, you're trying to revolutionize in a change way, going from, an infinite number of different formulas of TPN to 15 standard to choose from.
Yes, I usually call this reverse precision medicine. I tell people that you have to be able to do standard practice first before we are able to go into more advanced, let's do it differently for everybody. Right now, there is large amounts of physician-specific bias in how TPN is done. We first need to get it to a good standardization level before we can do it for everybody differently.
Thank you so much.
Last question, Emma.
Along the same lines, I think this was in your application, a risk that, you roll it out to the hospitals, they get the AI, they get the formula, and they say, okay, now we'll just use our own formula or, our existing method for manufacturing the TPN. What's the value proposition of them then using your manufactured product?
There are 2 answers. I will give you the official answer and then I will give you my own answer. The official answer is that we are not going to give the AI away to people without any conditions. We know people's volume. So we are going to tell them that you're going to have access to the AI for free as long as you order 80% of your TPN from us. And the key ingredient here is not really what goes into the TPN bag. We are going to publicly announce that to everybody. It's going to be on the labels. but who needs to get which one when? That is the critical piece that the AI calculates, and it cannot be calculated by hand. It can't even be calculated by standard AI algorithms. It's pretty sophisticated, and it's something that we have spent quite a few years developing. My personal answer to this is that nobody should ever even think about doing it, because we are going to mass manufacture TPN at a scale that nobody else does. And if people are thinking about, okay, what if I take this and go make my own TPN bags one at a time? It means that we are doing something very wrong. We haven't found product market fit. For some reason, our customers are not happy. If we do this right, because we have larger scale than everybody else, nobody should ever think about, oh, let me go make my own.
Thanks so much, Nima. Excellent. Well, give you a round of applause in here. Okay, wonderful. Great. Okay, that concludes our UCSF Stanford Pediatric Pitch Competition. Thanks to everybody. The judges will be meeting around 11:30, and we'll be announcing the winners around 4:15. And next we have our chancellor's speech. Thank you.
Thank you, and thank you, Usha, Anuradha, and Willie for moderating. And I think they did an unbelievable job of staying on time. So that's always a challenge with all the information that's being conveyed. Thank you to all the presenters. We had over 60 applications, so all of our pitch competition presenters here are in fact winners. So congratulations to all of them, and we look forward to working with them. And thank you to all our judges. We have an incredible panel of judges, and I know it's a lot of hard work, and they have a really hard job, as you can see by the incredible presentations. I have three kind of general observations. One is just reflecting on how much better the pitches and products are from years ago. Just really doing an incredible job. Two, and I think that's in large part due to the Pediatric Device Consortium, and so much thanks to the FDA, as well as to the partnership between academia and industry. I think that we've gotten much better working together, and I think that's really gratified by that and appreciate that. Two, which is really fundamental, is the common challenge that you can see of how to acquire data, how to interpret data. We have new biomarkers that are coming online all the time, and these are just the presenters had some of the examples of this, and how to present this in a usable format to patients and to providers. So that's a big common challenge to everybody. And three, I think because the addressable market in pediatrics is so small, I think we had repeated comments and questions from the judges about what other use cases are there so that you can make your entity a commercially viable entity. So I think, just some general observations. Now, as far as the rest of our program, we have a really exciting program. As mentioned, we're going to have the Chancellor of UCSF, Sam Hoggood, give the keynote address. We have a really great program on real-world evidence, which I think is germane to everything that was presented here today, followed by lunch. And then we have a great, exciting discussion on artificial organs led by Alan Flake and Shubho Roy. And then really a wonderful presentation. I think I saw Tim walk in recently. Tim's going to give our Trailblazer speech on the pediatric moonshot, which has been a passion project of his. And then finally, we'll have an internal description of some of the programs that have come out of UCSF under Mike's leadership. So thank you all for coming, and we'll take a break until, I believe, 11 o'clock. So we have, I think, a 25-minute break, so thank you.